All right, we're going to talk about vascular diseases. Now my heart's going. Okay, vascular diseases are really, to understand aneurysms and dissections, you really have to know the anatomy really well. Okay, this is where we're going down the future. Okay, down the future, this is a, believe it or not, this is not a drawing. Okay, this is a CT enhanced picture. Okay. And this is how the technology is rapidly advancing. Okay? If you told me that this was available back in 1995, I would have said, yeah, dream on, science fiction. Okay? This is actually real time now. And they actually have programs that actually will actually enhance the signal and change the color just to make sure that you know what you're looking at. It's pretty amazing. I mean, I think that's pretty cool. Okay? So the beauty of that is that once you start knowing the anatomy, things that would normally not make sense, why are these people getting these symptoms, make a lot more sense. Okay? The aorta runs up from the heart, which is called the ascending aorta, going towards the brain, and then it branches into major arteries. We call the innominate artery, the common carotid artery, okay, and then the subclavian artery. And eventually then destitches the aortic arch, and then it goes downwards. So the aorta is literally going from front to back, and then it descends rapidly via the descending aorta posteriorly in the left side of your chest. Okay, so if you really want to repair the aorta descending, you're looking at doing a thoracotomy. If you're looking at doing an anterior approach, you have to go through the sternum to get to the aorta. Okay? Now, there is important structures that the aorta comes by. The trachea is one of them. It also goes by the esophagus. It also goes by two nerves, which are the recurrent laryngeal nerves, which can cause compression on those, and you can get symptoms of it. Okay? Now, what I did here for you is this is what I expect you to know for your exam. Okay? These are the pictures that I expect you to know. I expect you to know the ascending aorta, how it splits into the innominate artery, okay, also called the brachiocephalic artery, and how then it breaks into the right common carotid and the right subclavian artery. There's also a missing in here, which is the vertebral artery. In addition to that, you have after the innominate artery is the left common carotid artery, and then you have your left subclavian artery. The attachment point, which is not shown here, is the ligamentum arteriosum, which attaches to the left pulmonary artery. Okay? That's where dissections take place. And then when you go further down, this is the descending aorta. Okay? You also get, once you get the crux, the crus of the diaphragm, you pass that. Now you're in the abdominal cavity, and then you have the branches off the aorta, which the topmost branch is the celiac artery anteriorly, followed by the renal arteries, followed by the superior mesenteric artery, which is right above the renal arteries, followed by the renal arteries, followed by the inferior mesenteric artery. And then you see the bifurcation into the iliac arteries and eventually the femoral arteries further down. Okay? You need to know the anatomy. It is relevant to what you do. Okay? When we're talking about ascending aorta, okay, you got to know what the branches of these are, because if you cut the blood supply to these major arteries, the left common or the right common carotid, you will cause the person to develop a stroke. So you get all the neurological symptoms if you begin to impair these blood vessels. In addition to that, you will lose blood supply to the arms, depending on where you put the cross clamp on. Okay? And we'll talk about the artery of Adamkiewicz a little later on, so what that clinical relevance to the spinal cord is, and we'll show you that in a few minutes. In addition to that, you should know about the abdominal aorta and where most aneurysms occur in the abdomen, which is infrarenal. Most of the aortic aneurysms are infrarenal, which is good because it has a much less risk. Okay? If you have a suprarenal aneurysm, you have a much higher risk of having renal failure, okay, when you do the abdominal aortic aneurysm repairs, which we'll show you in a minute. Okay, what is an aneurysm versus a dilation? The book doesn't really go into it as well as I wanted to, so I really want you to know the difference. Okay, the first thing we're going to talk about is an aneurysm. Okay? An aneurysm is basically a dilation of an artery. Okay? The way we talk about the major conducting arteries is due to what's called fusiform aneurysms. which means that the aneurysm follows along the artery and doesn't cause a huge little outpouching. If you look at cerebral aneurysms, they tend to be berry aneurysms, which are like little berries on the side of the grapes. They're like grapes. Okay? You can cut them off, and it doesn't cause any problems with the main pipe. These, on the other hand, is fusiform, which they actually involve the whole pipe, and they cause, to fix it, you got to repair it. You got to take it out. Okay? The problem with this is that as you develop aneurysms, the body does one thing very peculiar. It begins to fill it in, okay, because it only wants a certain caliber inside that artery. So it begins to fill that excess space with something, which is actually cholesterol deposits, as well as fatty and calcium depositions. So when you actually open up the aorta, and if you've never seen it before, it's actually pretty shocking. Okay? The inside of the aorta looks like pure lipid. It's disgusting, white, grayish, black material. It's actually horrible to look at. You know in your mind that's really not good to have in your aorta. You know, that's really not healthy. And what is really impressive is a special instrument the surgeons pull out. They usually are jokingly say, "Let me have the special instrument." And you invariably, everybody snickers in the room because the special instrument is a spoon. I'm not kidding. It's a typical stainless steel spoon. They go in there, scoop it up, plop it on the side of the table. So it's like having soup. Okay? This stuff is not good. Okay? What's important for you to know, because it forms this kind of deposit, is that arteriograms can fool you into believing that the aorta is normal. Arteriograms will only see the internal diameter of the actual artery that you're shooting the dye into. So a lot of times you cannot pick up that you have an aneurysm in these people. The only way to pick up an aneurysm is a CT or echo, okay, or some other visual way or an MRI to look at the aorta directly. Okay, so when you see these are the different aneurysms that you may form. You may have ascending aneurysms, you may have aortic arch aneurysms, you may have descending aneurysms, or you may have something like this where it involves both the thoracic and abdominal descending aorta. Okay? Now, you can see there's many different places where the aneurysms can take place, and each one has its own variable possibilities of repair. The mechanisms of aneurysm formation are usually due to hypertension, prolonged atherosclerotic disease. The most common one post-World War II for an ascending aneurysm was syphilis. Syphilis was rampant during World War II because of the hygienic conditions the soldiers were fighting in, plus just the inadequate availability of women at that time. And you had deceleration injuries may also be cause for aneurysms as well. Usually what you see with aneurysms formation from deceleration injuries is you see a small minor tear that's not really recognized, and eventually the dissection closes up, but it damages the aorta and eventually causes dilation, causing aneurysm formation. The aneurysms that you see in the ascending aortic aneurysms are type 1 and type 2, are usually seen in middle-aged males, okay? And you tend to see this ascending this way. What do you see? Well, what kind of symptoms do you have? Okay, for one thing, is anything that aneurysm can compress will cause symptoms. Okay, so the first thing that person may actually have is get inspiratory stridor from tracheal compression. Okay, you may also get esophageal dysphagia because the person has a compression on the esophagus. What they usually tell you is they have no problems with drinking liquids. Okay, but when they drink solids, that's when they feel like something obstructing. Okay, so because solids are getting caught up. The other thing that the person will develop is increasing hoarseness. Okay, and the reason they're getting increased hoarseness is because the recurrent laryngeal nerve that comes down here gets increasingly compressed as it goes through around the aorta. Okay, specifically the one I'm talking about here is the left recurrent laryngeal nerve that crosses usually underneath the aorta and then ascends back up and basically affects your vocal cords. You may also develop strokes from carotid occlusions. You may also develop acute heart ischemia due to coronary occlusion. You may actually also get acute tamponade and acute AI. which I'll show you. That's usually more symptoms of dissection than of aneurysms, and I'll show you why in a minute. Chest x-ray, usually we'll see a widened mediastinum. Really the pathognomic sign, the CT scan is really the better way of diagnosing these, as well as an MRI. Medical treatment if for an aneurysm, not for dissections, is for aneurysms, is to decrease the pulse wave activity. It also can be used for a temporizing measure so you don't worsen the dissection, which will show you what a dissection means in a minute. But pulse wave therapy basically means that you've got to diminish the pulse hitting the wall, so you want to decrease heart rate. You want to decrease the amplitude, which means you decrease the contractility. And you want to also not have a huge pulse wave hitting, so you don't want to have a huge stroke volume, so you can limit the preload as well. So dropping preload, dropping heart rate, and dropping the actual contractility all help. What does not help is SVR unloading. SVR unloading may actually cause an acute dissection from taking place or the aneurysm to actually rupture. Not something you want. What's that? Aneurysms. But it's a temporizing treatment for an acute dissection. What is a dissection? A dissection is a tear in the actual aortic wall. If somebody tells you you have an aortic rupture, people are usually dead, okay, before they come in. The only people that actually tolerate aortic rupture are the ones that have abdominal aortic ruptures. Okay? Because they rupture retroperitoneally, and then they will bleed for a while, and then it'll tamponade, it's closed. So the only people that really survive an aortic rupture are ones that have actually had it going into the abdomen. But if you have a rupture in your chest, all the blood pours into your chest, you get a hemopneumothorax, and then the person's dead. Okay? So that's usually not a problem that you have to deal with. Okay? But if you get a dissection, on the other hand, what you're bleeding is you're bleeding through either the intima or the muscularis. Okay? It could be one or both. If it goes all the way through the adventitia, which is the outer layer, and it bursts through that, then it's a rupture, and the patient usually dies. Okay? Well, what happens is the intima is torn, and as soon as the intima is torn, then blood begins to pool inside, okay, the adventitia. And what you get is literally the layers peel away from each other. And when you look under an echo, you go like, man, that is so cool. Okay, just like you see, just like the book does, which just says it tears away from the wall. Okay, so the adventitia holds everything in place, but the blood starts compressing and inward, causing the actual caliber of the internal lumen to diminish. Okay, and what it looks like when you look at somebody with an aorta that has a dissection, it looks like a blood sausage. The normal aorta looks pretty pink. Okay, but a dissected aorta looks like a blood sausage, dark red. Okay, thick, it looks full, it looks nasty. Okay, it looks like, man, this is something you don't want to touch. Okay, nothing my favorite. We were in there one day. We had a nice aortic dissection. Patient's in lateral position. The surgeon saying, man, this looks really ugly. He says, I got to be real careful. And I'm going, yeah, great. I know this guy's hands. He's about as careful as an elephant going through a house. Okay? So he puts the clamp up to it. He just touches it, and the sucker goes, boom. Okay? And the blood goes everywhere. Okay? And I tell you right now, when you tear you go from a dissection to a tear, you're losing 60 to 100 cc's out to that hole per heartbeat. Okay? Within 100 heartbeats, there ain't much left. Okay? The good thing is after a while is that all bleeding stops. And then you can apply the clamp and it sort of works. Okay, and then we resuscitate and get the patient back. Okay, but make sure you have cell saver when you're doing this because you never know when this is going to happen. Now, a dissection arises from an aneurysm a lot of times or due to trauma. Okay? If you have a dissection, the type 1s arise from the ascending aorta. It's 70% of all cases. Okay? We saw this on a 54-year-old gentleman the other day who decided to try out a new exercise program. And during the exercise program, he decided, you know what, I used to lift 350 pounds when I was in high school. And when I saw him, I said, dude, man, I'm doing the same thing. I'm trying to exercise, but you know what, that was in high school. When's the last time you lifted 350 pounds? High school, okay. So he decided to show off his son that he could lift 350 pounds. And you know what? He did. The only problem was he dissected his aorta completely, okay? And he came in with acute aortic insufficiency. The aortic valve actually blew out completely because this blood extravasated around, and he'll show you a picture of it in a minute, that basically caused the aortic valve completely become incompetent, and he had acute AI. Okay, this guy went to the operating room immediately, and they actually, believe it or not, he survived the event. The next 2 days later, when I came by to visit him, I said, how you feeling? He says, yeah, I'm doing great, doc. Says, the only problem is this food sucks. He says, you're done fine. You haven't lost any of your brain cells. So he was eating a steak, or supposedly a steak, that they were feeding him, so it was kind of interesting. Type 2 is a rise from the ascending aorta. It's usually associated with Marfan syndrome. And type 3 is distal to the left subclavian artery. Okay, which is usually seen here. That's type 3. Usually it's due to deceleration injuries. It's the most common one. This is what Lady died of. And she went from a dissection to a rupture. Now, that was a DeBakey classification I just told you about. The DeBakey classification, depending on which side of the country you live in, if you live on the East Coast, most people, and up to Texas, you use the DeBakey classification. But when you live over in California, you tend to use a Stanford classification. Okay? And the reason that they've done this is really both these are bogus. Okay? It's really a waste of time, both of these, to memorize, because what you end up seeing clinically is you see a variant of it all the time. Okay? So this is more for generalizations to teach people what you do in different disease processes. One is basically involving the type A, which is involving the ascending and possibly descending, and type B is purely descending. Okay? A type B or type 3 has to be repaired through left thoracotomy. Okay? A type 1, type 2, or a type A has to be repaired with an anterior approach or sternotomy. That's why they teach you that differently. Okay? What do you actually do when you do these ascending aortas? First of all, you make sure you put an A-line. The A-line is really important where you put it because it depends on where the clamps are going to go. Okay? And we'll show you that in a minute. Okay? For ascending aortas, you put the A-line in the left radial artery. Okay? The reason being is that you're going to completely occlude it, so it doesn't really, you're not going to get any blood flow to the right side anyways. Okay? So most people put it in the left radial A-line side. What you should be doing is putting EEG or carotid Dopplers, because invariably you're going to have to do a cardiac standstill to get this repaired, because you are going to have to shut off the heart completely most of the time. And the other thing is, depending on where the aortic tubing is going to be able to go, if you're already beyond the aortic arch, then you basically are not going to have any blood flow going to the brain. So you really are going to do what's called cardiac standstill, and you're going to have to protect the brain for about 25-30 minutes to prevent it from dying. So one of the things that you can do is cause them to go into a very cold state. You can drive them usually about 19 or 17 degrees Celsius, so you make them severely hypothermic, and then you're going to give drugs to try to prevent the brain from developing any form of EEG activity, which is either high-dose pentothal therapies, which most of us do, or consideration of giving benzodiazepines. Most of us go with barbiturates to repair it. What they do with the aneurysms, they remove the section after they put cross clamps above and below. Okay, and once they put the cross clamps above and below, they cut out the aneurysm, and then they replace it with a vascular graft. A lot of times the aneurysms are not done by where they actually cut the aneurysm away. They actually just split it open, and then they suture it inside, and then they close the aneurysm around it. So that way you leave the Gore-Tex within inside of an encased space. That helps prevent the bleeding that occurs with the Gore-Tex, because that way the blood goes around it, and then it helps maintain the blood around it and helps it clot around the actual vessel. Within about a week's time, the actual Gore-Tex endothelializes, which means it actually redevelops vascular tissue inside this Gore-Tex. That's why it's made with little perforations, so the cells will begin to attach and actually revascularizes and does a nice job of preventing. After a while, you don't need to give anticoagulants to these people. Okay. Here's what you see. This is a dissection. Okay, you'll see it rip apart like this, and you'll see the lumen cause a false lumen to develop. This is a true lumen because that's where the blood's running, but this is a false lumen, and you'll see compressive forces, and it decreases the caliber. If it dissects them into the carotids or the innominate artery, it causes strokes, so you see big problems with it. Okay, whoops. Sorry about that. Okay, this is what, we skipped. Okay. This is what happens. This is how they treat an aortic dissection. If it's an ascending aortic dissection, they go through the anterior approach. Okay. What they'll do is they'll put in a cross clamp above and below. Okay. And then they repair the area where the tear is at, and they put in a graft. Now, the dissection goes downwards, and it causes the valve to be repaired. We have now systems where the actual Gore-Tex is attached to the aortic valve replacement that you're putting in. So you put a valve replacement, and you replace the whole root. And then you have to re-anastomose the coronary vasculature back to this graft as well. So it's a big operation. Okay? If you have a ascending aneurysm problem, again, you're not going to perfuse anything in the upper extremities. So to do that, you really have to shut down the heart and also complete cardiac standstill, which means that you have no blood flow. You're not going to be able to go on bypass. People have tried to do a fem-fem bypass for these people, but then how you still get in circulation in the brain? The answer is you don't. So it's all, you have to put this person under deep, deep levels of suppression for the brain to be survivable. So you have to make these people hypothermic, and barbiturate coma is also a consideration. Postoperative management is this: you have to maintain a very tight hypertension control. You cannot let this person get hypertensive and tachycardic postoperatively on you, because what will happen is you'll tear the graft right off, and that's devastating. I've seen it happen one time where somebody wasn't paying attention, blood pressure went to 240, the suture line's all busted, that was it, case over. Okay? So you really, these people shouldn't be taken to, they were doing fast tracking, which I don't understand why the hell they did it in the first place, because this is not one you should fast track. You should keep these people asleep, comfortable, just take them to recovery phase, ICU phase, and let them handle it, emergence, and tell them to do it really slowly with tight blood pressure control. There's a higher incidence of CNS dysfunction with ascending aortic aneurysms because of this issue of having to shut down the brain completely for about 30 to 40 minutes. Type 3 or descending thoracic aortic aneurysms, which eventually develop dissections, are usually asymptomatic if there are aneurysms, but if there's due to deceleration injuries, they become symptomatic very quickly because most people have severe back pain, hypotension, and if you check their pulses in comparison to the upper extremities, they're much lower in the lower extremities compared to the upper extremities. Okay? They're associated a lot with a myocardial contusion because of rapid deceleration as well. What you do is, the new things that they're considering doing is endovascular stents. These endovascular stents, they actually insert through the femoral sheath. This is a slightly different picture now. And what they do is they open the stent within this, and then it repairs it internally. They're starting to try to do this. I can tell you, though, it's pretty risky because when things go wrong, it ruptures, and then it gets really ugly very fast. So you got to, not only going from a flat position, you need to be in a flat position when you're doing it, then you got to put this patient rapidly into a lateral position to open up their chest. It's a nightmare. So you got to be very careful with this. Okay? Yes? What the stent does is it's supposed to find where the area of the intimal tear is at, and it covers the intimal tear. If it doesn't cover the intimal tear, then if you still occlude most of this, it'll actually stop the hemorrhaging from taking place anymore, as long as you're close to it. Okay? My biggest issue with this is that a lot of times it's too close to the subclavian artery, and you can't get the stent close to it, because what will happen is you'll occlude the subclavian artery with a stent, and you'll lose all blood supply to that arm. So a lot of times these procedures that they're touted as going to be the way of the future end up not working out right now because of technical reasons. Eventually what they'll end up having is to have specialized stents that will have variable orifices or be manufactured for that individual rapidly, and have it so the holes are open, and that way you can put the stent over it and just manipulate the stent so when it deploys, it's got holes that allow blood flow to go out through those ways. And that's what I foresee in the future, but that's still a long ways away. There's a lot of technical hurdles still to deal with. Okay? when we were told that aortic aneurysms for the abdomen were going to be completely taken over by these things, still they have a lot of technical problems. 80 to 90% of them are now being done this way, which makes it, the outcome much better for the patients. They can actually be discharged the next day. Okay, versus if you don't, these people are in ICU for 2 to 3 weeks. A big difference with a high morbidity and mortality rate. So it's better to do it with these stents if we can get away with it. The treatment for type 3 dissections is conservative medical therapy? Absolutely not. It's a waste of time. It's surgical intervention. I've seen people try this conservative medical therapy and invariably it ruptures or something bad happens, so it's not usually what I would do. If it was me, I'd have a stent put in. If not, I'd have the thoracic procedure done because your chance of surviving is pretty low. And we'll talk about this in trauma later on. Management of anesthesia for this is you need to put in a PA catheter, right radial A line. This is a right because it's so close to the left subclavian artery, so at times the left A line will be lost. You also need to consider putting a femoral A line, that way you can get adequate perfusion, see how you're perfusing to the lower extremities. These people all need double lumen tubes, okay, because you need to isolate the lungs so the surgeon can repair the area with maximal visual field. Okay. If you have only a single lumen tube, then the ventilation will go on both lungs, and the surgeon will have to be pushing on the lung while he's trying to repair this, which delays him. Okay? When we talk about this in trauma again, I'll show you how that's fraught with some problems. Postoperative course with descending aneurysms, the biggest issue with that is that you have the artery of Damkowitz. The artery of Damkowitz is this branching, let me go to the next picture, is a branch of these little radicular arteries that come off the back of the aorta, all the way going down, one segment per segment down. Okay? And it provides the actual anterior spinal artery. The danger of it is that the anterior spinal artery, if you cut the blood supply to the artery of Damkowitz from a cross clamp being above it, then everything below that area will get underperfused, and the person will develop anterior spinal cord syndrome, which means that the person will not be able to move their legs but feel their legs after the surgery. In other words, they'd effectively become paraplegic with normal sensation to the lower extremities. Okay? So it's one of the few things that, also when you lose this artery of Damkowitz, you get severe sympathetic response, where you get total loss of sympathectomy, so you get a neurogenic shock that develops. And it's rather impressive. Abdominal aortic aneurysms, the next thing we'll talk about. Abdominal aortic aneurysms usually due to atherosclerosis. It's usually seen males, especially white-collar workers, people that are sitting in their desk all day long. Okay? I truly believe the major mechanism behind this is because your femoral arteries are completely occluded for many, many hours. And a lot of these workers, when you sit and talk to them, ask them, what are your legs like when you used to work? Did they fall asleep all the time? And a lot of them tell you yes. Okay? So it tends to be familial because most people that are white-collar workers tend to be white-collar workers in the next generation. Okay? So there is a higher tendency for certain families to get it. It's not sure if it's familial tendency or rather just job-related tendency. It's most commonly seen as infrarenal. If you're bilaterally occluding both femoral arteries all the time because you're sitting 90 degrees and working on a computer all day and your legs go to sleep all the time, that's not a good sign. You need to be able to lean back and work more efficiently. Okay? They got some really cool chairs nowadays where you actually go into what's called zero chairs, that you can literally have your keyboard up and you can work upside down. Well, I thought it was pretty cool. I think those people won't get aneurysms. They're going to get the sleep syndromes, that's all. Symptoms that you get is painless at times. Most of these people don't have any discomfort until it tears. But when you put your hand on their belly, you can actually feel that the thing is bouncing back and pushing on you. Okay? And that's really not normal. Okay? When you look at it under ultrasound or CT, this is an angiogram, and even despite the angiogram, you see an aneurysm. So this is much bigger than that because of the atherosclerosis around it. But once you exceed 5 centimeters, that's when you have the incidence of rupture goes up considerably, about basically 70% incidence of spontaneous rupture per year. So it's pretty bad. If you have 5 centimeters, you need to have it repaired right now. If you don't wait, if you decide, well, you know what, I'm going to play the odds, and I'm not going to do anything, well, you're most likely going to go on to rupture within a year. 70% of people that have greater than 5 centimeter abdominal aortic aneurysms will eventually rupture. The classic triad, which only occurs in 50% of people, will be severe hypotension, back pain, and pulsatile abdominal mass. Okay? Most of them that actually survive to get to the hospital are bleeding retroperitoneal to the left side. As a consequence, this will tamponade the aorta and stop the bleeding, or at least partially stop the bleeding as long as you get hypotensive. The downside to it is that if you start giving a lot of fluids to this person, guess what? Their bleeding resumes. So be careful. Don't start resuscitating these people until they get into the operating room. Make sure you have 2 big IVs. Make sure you have an A-line before you put this person to sleep, and put a big cordis in their neck so you can fluid resuscitate them rapidly. It's almost always indicated to do this with a AAA, with a PA catheter as well, because you're going to cross clamp the aorta, and that may cause significant hemodynamic effects. Management, general-wise, is preoperatively is key, and the reason most people die from AAAs that are ruptured is because you don't have enough time. Time is your enemy. They usually bring these people up, and their legs are blotched. And when you take off their clothes, you have no blood flow to the lower extremities. Their legs look like they're purple blotch marks all over the place, and you can see that the body's dying from midpoint down. Okay, the upper part looks okay. The person's talking to you, and it seems like everything's fine. They're having pain usually, but you see the lower body down is dead. Okay, and you know eventually within about 6 to 8 hours they're going to be very, very dead. Okay, so you really need to get in there pretty quick. Okay, now the way it's being done in the past is that we would do it with, we'd open up the belly immediately and then rip into this aorta, and invariably what happened is the aorta would rupture right in front of our face. Or the clamps would go inappropriately in the wrong place, and the clamps would go right through the aorta. Sometimes that happens too. Case is over when that happens too, and you lose control of the aorta. So be prepared for things really to go bad very quickly. Your induction has to be very stable. You can't have the person rapidly get hypertensive because then you'll rupture. So I would tend to use esmolol. I give a very tight control to maintain a normal heart rate. Try to get the heart rate usually down to 60. If their blood pressure is really, really low, then I just give them etomidate, sucks, and intubate them. Because usually, invariably, they're all full stomachs. Maintenance is you can give them low-dose Forane. Sometimes if you get really hypotensive, just scramble them with some scopolamine and just run them on minimal. Don't give them any narcotics until after you got it stabilized. Okay. The key to this is before you come off cross clamp is to make sure that you have adequate preload inside the heart before you start coming off clamp. Okay? The other thing that you want to do is before you go on clamp is to give mannitol to try to hopefully protect the kidneys to keep them perfusing, as well as sometimes people give Lasix as well, and some people give low-dose dopamine. Be very careful about giving dopamine to these people, as you may increase shear velocity and as a consequence cause more dissection to take place or even a rupture. So I don't really recommend dopamine in these people in the acute phase. If it's a long-standing abdominal aortic aneurysm that's not ruptured, then you consider low-dose dopamine if you want to. Most of us are going away from that. Say we're using more of the renal perfusion drugs. I can't remember the name of it right now. But it's got a special name for it that we're using now too. Regional anesthesia may also be is indicated at times for postoperative pain control. The problem is you want to make sure that you don't give a high dose of local anesthetic, so it would impair the muscle relaxation. Because you want to have this person be able to move their legs immediately after surgery, so I only give 0.25% or less, or 0.125% Marcaine, to make sure that they have good motor function after, to make sure that I don't have any artery of Danckowitz injury. The other thing too is that these people are going to go, if it's elective, that's different, but if it's emergent, forget about it. Okay? You can't put an epidural in them because you are going to fully anticoagulate these people during the procedure. And if you get a blood tap, then you're going to get an epidural hematoma. Okay? So you can't get a venous insertion. If you do get a venous insertion in an elective case, it's canceled. It'll be done the next day. And of course, it's not going to make anybody happy, to say the least. But you explain that up front. Now, what is the stents that everybody's talking about? What the stents basically are is we put a wire into either through the femoral artery or through the right internal jugular vein and pass the wire through the aneurysm, and then we put in this device that is able to deploy a stent, and then we put a balloon inside the stent to actually fully deploy the stent. So what you end up having when you're finished is this. This is what it looks like pre-insertion. These are the old models. The new models are much more sophisticated than that, and this is the device that actually deploys the stent within the aorta. Okay? So what you're left with by the time you're finished is that this is fully deployed internally, and you don't have to go surgically going in to repair it. This is a new way of doing it. It works much better for most patients. These patients that get these kind of procedures can be discharged the next day. Okay? Versus the AAA repairs under surgical repair, where you actually have to open to the skin and get to it. There's two approaches, transabdominal or retroperitoneal approach. Both of them require 3 to 5 days in ICU stay. So it's a much bigger procedure that way. The other downside to this is that please don't think that because it's an endovascular stent that everything will go fine. Okay, I'll never forget my first experience with this. I was told that they had this new fancy therapy. I was up in Northwestern University up in Chicago, and I was one of the professors up there. And I was asked to be involved in this, and I said, where are we doing this at? So, we're doing it in radiology. Okay, we're doing radiologies. And the guy says, well, I want you to do it under epidural. And I said, okay, you really want me to do it under epidural? I said, yeah, okay. And I was thinking, that doesn't sound right to me. Okay, so he did it under epidural. Okay, the patient had T6 block. He was great, totally awake, talking to us. They put these catheters in. They deployed it, and as soon as they deployed it, the aorta ruptured. Okay, in radiology, with no anesthesia machine. We were doing it under epidural. So all we had was an ambu bag, our anesthesia card. It was a nightmare. Okay, of course we throw this guy into a gurney after we intubate him rapidly with etomidate with a blood pressure of 40, run him back to the OR, okay, where we slash and burn this guy, get in there, and of course he dies intraoperatively. Okay? So not a simple procedure like you're being told. When everything goes fine, it makes it look really easy. But all these people, they all buy general anesthesia in my book because if I get hypotensive, I'm not going to be fighting an airway while I'm trying to keep this guy alive. You got to get my hands busy. So these people buy tubes until the surgeon proves to me that he's an expert. Anybody who tells you, well, I'm just doing it for the first time, and if they have the rep in the room with them and they're going, they're telling him what to do, they're not an expert. They're just learning. Okay, and just like you are learning, who's watching over you? Dr. Nolan or whoever else is watching you. Make sure you don't screw up. They're already full-time attending staff. And these new procedures inherently have higher risk. And they don't know the risk because they haven't encountered enough of it. Just be prepared that things are going to go wrong eventually. Okay? And if you're prepared, you'll be fine. Okay? Peripheral vascular disease can be broken down into several things. Okay? Peripheral vascular disease can be from chronic arterial-occlusive disease, which is atherosclerosis, or acute peripheral arterial-occlusive disease, usually to embolic phenomena that occurs either from the heart or from other things, including thromboemboli from other atherosclerotic plaques higher up in the system. You can also get systemic vasculitides, which are inflammatory reactions inside the vessels, and you get vascular syndromes such as Raynaud's disease or Kawasaki's disease. The vasculitides is what I'm going to talk about initially, and these are rare syndromes, but they do occur. They're basically inflammation that takes place inside the arteries, causing eventual occlusion of the internal lumen. In the Takayasu syndrome, you have aortic arch arteritis and pulseless disease, thromboangiitis obliterans, which is also called Berger's disease. I'll show you that because we have a higher prevalence of this in this area. You also have Wegener's, which is lymphatoid rheumatica, and polyarteritis nodosa and henoch-Schönlein purpura. What is one of the things that you can see from any of these diseases, and I'm sorry this is out of sequence, this is subclavian steal syndrome, and it occurs when you have an occlusion, acute occlusion, and sometimes it can occur from Takayasu's disease. You can get acute occlusion of the subclavian artery, which then causes a shunting away from the cerebral blood flow because the carotid, instead of flowing upwards, it flows downwards to try to provide the blood supply to the arm. This leads to acute syncope, vertigo, ataxia, even if you develop ischemic strokes and arm ischemia. Okay, so you can get it on both sides, depending on which side you're talking about. You also can have coronary steal syndrome. This is a more rare disease process. Again, this could be an arteritis that develops after surgery, where the actual aorta itself is actually narrowing. And when they do a Lima graft, they actually develop subclavian steal syndrome. Okay? The coronary, instead of going down the LAD or whatever the graft it's at, it goes back up the internal mammary and it begins to shunt through the subclavian artery, because you have partial occlusion of the ascending aorta. Okay? So that's something that happens. Usually, again, symptoms of, if you're affecting the vertebral artery, symptoms of stroke. Some patients also develop angina pectoris because, of course, the LAD is not being adequately supplied. This is very, very rare, thank goodness, but it does happen. Takayasu's disease is basically a chronic inflammation of the aorta. As you can see when this angiogram here, okay, see this right here? That is the actual innominate and subclavian artery being completely compressed internally by this inflammatory mediated reaction. Takayasu's disease tends to be seen in Asian and Mexican descent patients. So there's predilections to these people, and they tend to be mostly in women between the ages of 20 to 50 years of age. Okay? This eventually leads to strokes. It leads to decreased pulses in the upper extremities, and also sometimes called Pulse's disease. Okay? You tend to see vertigo, syncope, seizures. You'll have also occlusions of peripheral arteries. You may actually develop cardiac valve dysfunction. The things that you'll see as well is it begins to affect pulmonary circulation as well, so you get pulmonary hypertension, you get a lot of VQ mismatch. The renal arteries may also be affected by this, leading to renal artery stenosis, renal dysfunction, renal hypertension, and may also be associated with ankylosing spondylitis and rheumatoid arthritis. Treatment is, because it's a vascularity, it's an inflammatory reaction. It's the steroids or an anticoagulation. Anticoagulation, because of decreased lumen caliber, increases the risk of thromboembolic phenomena from taking place. This is Buerger's disease. Buerger's disease should be very important to you because we have a high prevalence of this in this area, because people that have had this problem are told usually to go to warm weather climates. The problem with it is it's a genetic variant of an inability to break down nicotine. Okay? So these people have an increased vasoconstrictive effect when they're exposed to nicotine. So smoking definitely makes this person worse. And all you have to do to treat Buerger's disease is tell them to stop smoking. I had one VA patient I'll never forget. When I first started as a medical student, he had most of his fingers amputated. By the time I finished my residency, which was 8 years later, the guy had his amputation all the way up to the elbow, and he had both his lower extremities cut as well all the way above the knees. Because he would not stop smoking. He's still smoking even with that, using his stubs of his arms. So, just amazing. Okay, and cold and trauma can exacerbate the syndrome as well. But really, the major topic is that you get dry gangrene, which is what you're looking at here, from the obliteration of the little peripheral arteries that occur from the chronic nicotine exposure. The symptoms that you get is migratory thrombophlebitis and intermittent claudication. Of course, the signs that you see is more pain in the extremities initially, the hands and digits. Treatments: smoking, avoid trauma, and avoid cold. Management is critical that you keep these people from getting cold on you. You need to position them carefully because they have increased risk of developing ulcerations. Okay? Do not put an A-line in these people because their peripheral vasculature is already hypersensitized, and they will go into acute occlusion of their renal arteries. You need to consider increasing their FiO2, and general anesthesia tends to be okay, but regional anesthesia might be better. You just have to avoid epinephrine. You can't give these people any catecholamines because they're going to vasoconstrict inappropriately in this situation. The next disease is Wegener's. Wegener's is a formation of granulomas that occurs over all sorts of areas of the body. For the importance of us, that it can take place in the nasal cavities, so there's increased risk of epistaxis. They may actually also form granulomas inside the trachea and in the lung. Okay? It may also lead to necrotizing granulomas to take place. So this is a high-risk procedure. The most common cause of Wegener's failure is kidney failure. One of the things that you see is that the hard palate can be involved in this and actually necrose the hard palate, which would make it difficult to put an NG tube down them, to say the least, so you have to be careful. The larynx may also become significantly narrowed, causing destructive lesions on the epiglottis to form. It's nothing more depressing when you go in there and you look in there and you see that the epiglottis is completely wiped out. And you really have to be very careful because you can induce rapid bleeding. If you have the granules forming the upper trachea, may completely occlude the airway, and that's usually evident because the person is developing stridor. Okay? If it's an extrathoracic event, which is the trachea, it's above the carina, then you're looking at when the person takes in a big deep breath, the actual airway will occlude during inspiration. Okay? If it's intrathoracic, then the stridor will get worse on expiration. So you have different kinds of lesions depending on where it's intra or thoracic involvement. A lot of these people who develop, Wegener's develop pneumonia because they completely occlude the bronchioles, and there's also, they have increased risk of hemoptysis. The typical things that you see is you get these target lesions that occur in the digits. You may also see central nervous system involvement, including strokes, peripheral neuropathy, skeletal muscle wasting. And the most common cause of death from these is complete destruction of the renal glomeruli, which leads to renal failure, which eventually causes death in most of these patients with Wegener's. It is an autoimmune disease, so people treat it with cyclophosphamide, which has associated other complications, but it also has a problem with decreasing plasma cholinesterase, which may give you a variable response to succinylcholine. Steroids, because it is an autoimmune response, is also a consideration. The next one we'll talk about is temporal arteritis. Temporal arteritis is a disease where you have unilateral blindness. It's from acute occlusion of the ophthalmic artery, which leads to unilateral headache. Treatment is high-dose steroids, but what you want to do is you want to make sure that before you start giving high-dose steroids that you diagnose it. What you need to do is you need to find where the temporal artery is and biopsy it. Okay? Just so you know, you have to watch what the surgeons are doing. I came in one time after the surgeon had prepped the area, or actually the nurse had prepped the area, and the surgeon came in and he was actually operating down here. That's not where the temporal artery is at. Okay? That's where your parotid gland's at. He was actually further down here, and your facial nerve is at. Okay? So you have to make a little comment, say, hey, you know, a little low, and the surgeon immediately said, yeah, and he went up, made another incision, repaired the first primary incision, and everything went fine. At least we didn't hit the nerve and cause permanent facial paralysis. That would have been a bad complication. So open your mouth and watch what they're doing. Don't just sit there and go like, I don't know anything. That's why you're there. Okay? Polyarteritis nodosa is a more rare syndrome. It's a multi-system disease. It causes acute inflammation of the small blood vessels. It causes renal involvement leading to hematuria, proteinuria, and hypertension. Treatment includes steroids. How do you actually diagnose this? It's actually difficult unless you think about the whole picture. These people have these large vessel arteritises, so they get strokes, migraines, vague pains from the muscles not getting enough blood supply to it. The lungs tend to be spared. The liver, unfortunately, tends to infarct as well as the bowels. Okay, these people tend to have gangrene and peripheral nerve damage as well. So it's a whole conglomeration of things that you see. This is a typical lesion of somebody with polyarteritis nodosum. We actually had a patient that came in like this, and the surgeon thought it was something else. And when we looked at the whole picture, we said, well, this is most like polyarteritis nodosum, and the surgeon didn't have to even do the biopsy. We just cleaned up the wound a little bit, and then we were done. Okay? The next one we'll talk about is henoch-Schönlein purpura. It's a children's disease. It targets the joints, kidney, and you can see this extensive purpura on the skin because it begins to cause disruption of the vascular, the capillaries of the skin. It's an autoimmune phenomena. Again, steroids usually the high-dose treatment for this. It becomes a confluent purpuric rash, which is what you're seeing here. The last thing I'm going to talk about, then we'll stop for 10 minutes, is Raynaud's disease. It's an abnormal reactivity to vasoconstrictive stimuli. What you see is an extreme whiteness because the blood vessels to that area have stopped having any blood flow to them. The pain is not during this phase. The pain is during the warm phase when the blood returns back to this area, and then they get pulsatile pain. They actually can feel the pulsations from their heart. And because they get severe ischemia, when the blood returns to the area, then it becomes extremely painful. You tend to see this in very high incidence in Florida because these people become very symptomatic in the cold weather. So doctors tell these patients, go to Florida or go to Phoenix. So if you end up going to Arizona, you'll see Raynaud's phenomenon a lot more too than normal. Especially in South Florida, you see a lot more Raynaud's than you'll see anywhere else in the country. It's often associated with other associated major diseases such as lupus, scleroderma, and primary pulmonary hypertension. So you need to consider that. Anybody who's got Raynaud's disease, make sure you're not in right heart failure before you're taking these patients back to the OR. You see pallor, cyanosis, erythema, edema, numbness, diaphoresis, burning, and throbbing pain are usually late signs from revascularization that takes place. Treatment is avoidance of precipitating factors, which is usually temperature related, but it's also related to smoking. So smoking cessation is critical to stop this disease from getting worse. And there's also a consideration of doing a sympathectomy on these people, so you can do different kind of procedures to do that, including now the new procedures that we're doing, which is we're entering into the chest and burning the sympathetics to the upper extremities to stop this from getting worse. Management is positioning is critical in these people. You've got to make sure that their temperature is maintained, so you've got to warm up the room. An A-line is really questionable, okay? Some people say it's not a good idea. Other people have done it. I would recommend you tend not to do this if you can avoid it, especially to the hand that's being affected. If the other hand's not being affected, it's a consideration if you really need it, or you may want to put it in a large blood vessel, such as an axillary artery or in the femoral artery. Regional tends to works fine, these people, as well as general, except you need to avoid epinephrine. And that's where we'll stop. Give me a 5-minute break, and then we'll finish up.